Good morning, and we're grateful to the European Hematology Association for the opportunity to share our work. I'm a physician trained in hematology oncology, but unlike my academic colleagues, I work for a company called CRISPR Therapeutics. Our work focuses on the treatment of two very important medical diseases, sickle cell anemia and beta thalassemia. As described on the left, both diseases are caused by defects in adult hemoglobin. Newborns with these diseases are not symptomatic because they do not yet express adult hemoglobin. They have a fetal form of hemoglobin which works and is fully functional to replace or substitute for the functions of adult hemoglobin. There are rare cases of patients who have sickle cell disease or beta thalassemia who are not symptomatic or only minimally symptomatic because they have persistence of this fetal hemoglobin protein into adulthood. And this fetal hemoglobin protein can fully correct for a deficient or defective adult hemoglobin moiety. Our approach in treating the disease is to try to recreate this naturally occurring condition. Shown on the right is the example of a newborn baby that has the diagnosis of sickle cell disease or beta thalassemia and in whom fetal hemoglobin is expressed. In most patients, the adult hemoglobin, HbA, is expressed shortly after birth, and the fetal hemoglobin levels decline and disappear, and those patients have a disease burden from these two diseases. In rare cases, as I described, the fetal hemoglobin expression persists, and our aim is to use the CRISPR-Cas9 technology to mimic these naturally occurring variants to increase fetal hemoglobin and ameliorate disease. The CRISPR system many of you heard about and was mentioned earlier is a bacterial immune system that protects bacteria from attack by bacterial viruses. The discovery of this system and all of the component parts was by Emmanuel Charpentier and Jennifer Doudna in 2012, who elucidated the fundamental rules for how to use this system for other purposes, for genome editing. And we use those exact same rules and mechanisms today, whether it's genome editing in bacteria or in yeast for engineering purposes, or in crop sciences, or in human therapeutics from this fundamental discovery. Our approach is to take a patient who has one of these diseases and to take their blood stem cells, which in the disease situation produces the diseased red blood cells. We take these blood stem cells from the patient and we use CRISPR-Cas9 to modify or make the changes that mimic the naturally occurring variants. And we introduce these modified blood stem cells, and our aim is to have these CRISPR-modified blood stem cells produce the red cells that now contain the protective fetal hemoglobin. Most of this process, with only exception of the CRISPR editing, follows a well-established set of mechanisms around autologous bone marrow transplantation. As you heard, the first bone marrow transplant happened 60 years ago, so we have considerable experience with this process. In our presentation later today, we'll evaluate a series of considerations. Can we make the changes that mimic these naturally occurring variants with high efficiency? Do these changes indeed lead to high levels of fetal hemoglobin production that we would expect to be protective or clinically relevant in the patient? Do we have an appropriate safety margin? Is there any evidence of an off-target effect of our editing, which we would want to try to minimize or avoid? Do these cells persist long-term? And can we show that our editing affects only the production of fetal hemoglobin and not any other characteristics, thus preserving the functions of these hematopoietic cells? And indeed, in our presentation, we'll show that we address each of these issues in turn, showing that it is appropriately efficient with high and clinically relevant levels of the protective fetal hemoglobin. The evidence to date suggests that it is promising from a safety standpoint, that the effect has a good chance to last, and that we're addressing the appropriate aspects of the cell and not causing any untoward effects. So in summary, CRISPR-Cas9 gene editing through this approach promises to increase levels of the protective fetal hemoglobin. We will show later today the high on-target gene editing or modification rates and potentially beneficial fetal hemoglobin levels, that we don't see any evidence of off-target effects or cellular defects in our studies to date, and we have ongoing toxicology studies to support the safety of this approach. We plan to submit a clinical trial application later this year to begin clinical testing next year in patients. Thank you.